its initial value. Is it class for nicardipine? Now the next one is nifedipine. You can reduce also by using nifedipine. So after using calcium channel blockers, if it fails, you can also use the next one, beta blockers, but generally beta blockers are not used. So example, we have labetalol. We can use beta blockers either in this case to use beta blockers, or use also beta blockers to maintain in this case. So labetalol is an example of beta blockers, 500 milligram. You can go up to 2000 milligram per day. Is it clear? Now the third one after the beta blockers, so third one after the beta blockers, we have the next one is so for the nifedipine, it is 20 milligram. You don't go more than 80 milligram per day for the nifedipine or the nicardipine. Nifedipine, you don't go more than 80 milligram per day. Now the next one we have the nitrate vasodilator that you can also use. Is it clear? Provided that everything has failed, like in the case of nitroprusside, which you can also use. So those are the different elements that you use as antihypertensive. So after the antihypertensives, you have to stop the convulsion provided the patient already has convulsion. If the patient has convulsion, you give diazepam. So in the management of status epilepticus, so the first you have diazepam. Is it you give first one diazepam. Diazepam is 5 milligrams. Is it that's 1 ampoule. So diazepam 5 milligrams in 10 mils of urine, 10 mils of normal saline. Sorry, you give 10 mils of normal saline, and then you pass it slowly until it has stopped. Or generally it is just 0.1 to 0.3 milligram per kilogram provided in pediatrics. It passes slowly until the convulsion stop. If it fails, you have to give it again after another 30 minutes. While the patient convulses again after another 30 minutes, you do it again. And if it fails, now you go down to phenobarbital. To give phenobarbital, you generally the dosage of phenobarbital is a maximum of 10 milligram per kilogram per day. And you should not exceed 1,500 milligrams of phenobarbital in one day. So it means that you can place 2 ampoules of phenobarbital in normal saline. 2 ampoules of phenobarbital in normal saline, and then you put at a certain flow rate so you should pass through the whole day. That's for stopping convulsion. After stopping convulsion, you prevent further convulsion. So you prevent further convulsion by using magnesium sulfate. So giving magnesium sulfate, first give 4 grams of magnesium sulfate IV, and then you give 5 grams. The loading dose of magnesium sulfate is 14 grams. 4 grams is given IV, 5 grams is given in each buttocks. IM on each buttocks. So 5 grams on one buttock, 5 grams on another buttocks. Now after 4 to 6 hours, generally the best is 4 hours. After every 4 to 6 hours, you give now 5 grams each buttocks, IM on each buttocks. So give 5 grams IM on one buttocks, and then the next 4 hours you give again 5 grams again on another buttocks. Then so that's how we're going to prevent the convulsion with magnesium sulfate, and it increases it is a very good factor that is going to reduce the mortality and morbidity in it's a good prognostic factor when you are using it in pre-eclampsia. It reduces mortality and morbidity in pre-eclampsia, magnesium sulfate. So it's always nice to give it. Every time that you give magnesium sulfate, you should evaluate for 3 things. The first thing you evaluate for reflexes to find if there is hyporeflexia. So if there is hyporeflexia, there is a sign of magnesium toxicity, so you have to stop it. The second thing, you have to evaluate for respiratory. If it is less than 12 cycles per minute, it's a sign of toxicity, so you have to stop. And the third is the urine output. If urine output is less than 30 mils in 30 mils per hour, you have to stop it. So that's why you have to place a urinary catheter in this patient in order to monitor the urine output for magnesium sulfate. Now the next element that you have to evaluate, so after speaking about the the stopping the convulsion, you have to give fluids to the patient. Fluids. Now, how do you give fluids to the patient? You give 60 ml per 60 ml to 80 ml per hour to this patient. Is it clear? So that is the fluid that you have to give to the patient. Is it clear? It's 60 ml to 80 ml per kilogram. Is it clear? Per 24 hours. So this is the total fluid that you have to give the patient. Now the question is, why is it that the patient is hypertensive and you give fluids? Because fluids is going to increase the preload, and the preload is going to increase the blood pressure. But why is that when a patient is hypertensive, you still give fluids? That fluid is very important. Is it clear? And the fluid should not be hypertonic nor hypotonic fluid. It must be isotonic fluid, particularly normal saline. Is it clear? It's normal saline that is being given, and it's given at 60 ml to 80 ml per kilogram in 24 hours. Now the question why the fluids need to be given, we have already explained on the pathophysiology of the ischemic acute tubular necrosis, that when there is an increase in blood pressure, you are going to have an increased hydrostatic blood pressure at the level of the glomerulus, which is going to result to a pressure natriuresis, which result to a increased loss of fluids, which results to a reduction in renal blood perfusion. Is it clear? And that reduction in renal blood perfusion results to an activation of the RAS system, which result again further to an increase in blood pressure. Is it clear? So in order to prevent this RAS system activation from the reduction of renal blood flow, you must give fluid to the patient. Is it clear? That's the first reason why you give fluid to the patient, in order to reduce that renal blood flow from the loss of fluid. Is it clear? So that is the first mechanism. Now the second reason why you give fluid to the patient is that what general I've also spoken about the fact that in a case of a patient that has pre-eclampsia, in the case of a patient with pre-eclampsia, we have also proteinuria. Is it clear? And proteinuria, we have the loss of the fluid volume of the blood vessels. Is it clear? The blood vessel was mostly made up of what? It was mostly made up of proteins. Since there is proteinuria, there is loss of the osmolar product inside the blood vessels. So in order to maintain that osmolar product of the blood vessels, you give also fluids which are isotonic. Is it clear? So you give isotonic fluids such that it should maintain that the osmolarity of the blood vessels, such that each compartment of the body fluid, that is, the first compartment is the intracellular fluid, second compartment is the interstitial fluid, the third compartment the blood vessels fluid. Is it clear? We said that the first one was maintained by potassium and proteins, second one was maintained by sodium ion and chloride ion, and the third one was maintained by sodium ion, chloride ion, and mostly proteins. In this case, since there's a proteinuria, there's going to be a reduction of this fluid. So in this case, you add fluids with sodium ion and chloride ion, such as to maintain this fluid space and to prevent edema from this other fluid space, and also to prevent dehydration. Is it clear? So those are the different elements that you have to evaluate in their management. The next thing in the management is to evaluate for the background. You find for the background and then you treat the background. You start with the hypertensive workup. Is it clear? Provided the patient has a risk factors of hypertension, start with the hypertensive workup to evaluate for a theories of hypertension and all that. After that, now you go to the next element, which is the follow-up.